Welcome to this week's episode of the Authentic Physician Show, where we have honest conversations about medicine, identity, and health transitions that women aren't prepared for. If you're a woman who's juggling work and caregiving, a body that no longer responds the way it used to, you're in the right place. And if you don't trust the healthcare system, that's okay, because today we're going to have an honest behind the scenes look of what it means to work in healthcare from two physicians. And today's guest, I'm delighted to introduce Dr. Ann Gonzalez. She has been really fantastic about doing a blind interview today because we just recently met and we were saying hello before the show got started, but we have no idea what we're going to talk about. So this should be fun. Welcome, Dr. Gonzalez.
Thank you. Thank you for having me. I've been looking forward to this.
I'm excited to. Why don't we start with very, very high level overview? You're a medical doctor by training. Tell
hmm
us a little bit of what you want us to know about your medical background, and then we'll jump in with some fun questions.
hmm Yeah, thank you. So, I am a family medicine physician and I've been in practice for ages, it feels like. But I've been, in the past 5 years, I've been practicing as a direct primary care doctor. And that's kind of how I got to the Facebook group where we met
Hmm.
because of that. And yeah, so family medicine, I went into it because I like doing all the things and having relationships with my patients. And as,
Yes.
as our physician listeners will know, that it's very difficult
Right.
in the current, healthcare system, in the insurance-based system, to have those kinds of relationships with your patients. And so
Absolutely.
that's why after COVID, my partner and I, we both worked at the same practice, and kind of just by chance, we were talking about direct primary care, and we didn't realize it, but each of us had considered doing it
Uh-huh.
earlier, just
Neat.
separately. And then when we found out, we were kind of laughing. We're like, oh, ha, 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 it'd be funny if we did that. And then we stopped after a second. We're like, wait a second, we could probably do that.
We can really make it happen. I love
Yes.
it. Oh, I
Yeah.
love it. That's fantastic. And I love the little slip up you did because I was thinking if you're working 80 hours a week and you have 3,000 patients, it's going to make it hard to have a relationship with your parents too, right? Your
Yes. Yes.
children, your
Yes.
significant other, all of them. So I think that was an apt misspeak that we should own for us. And so many of our listeners are working professional women. Many of them are, 35 to 55. They're in that crunch between parents and children, and they're often in the industry of whatever career they specialize in. And yet they still, beyond that full time job, come home and have their other full time job they're not paid for, right?
hmm
And when I think about that specific group of women, um, it's real, right? The struggle is real. And it's not to diminish it for any other group, but I sense that in many of my exam room conversations, that's the group that struggles the most.
hmm
Is that something that you've seen in your practice and experience as well, or would you offer a different perspective?
Well, I agree. I mean, I think that being caregivers, being women, we're very much
Mhm.
caregivers, and that in both in work and in your family life, of course, you want to give 100%, and that just leads to burnout.
Mhm. Yeah.
And so, yes, over the past couple of years, I've been trying to mentor new DPC doctors, and so I've talked with a lot of people, and so many times I've heard the same story where I was going to quit medicine. This
Mhm.
is what people say. I was going to quit medicine until I found direct primary care. And
Yes.
that's why they left the regular fee for service system, because they couldn't do everything that they wanted to.
Yes. Yes. And so for our listeners who aren't in clinical medicine, let's do a quick breakdown. You mentioned
Mhm.
two different options. I'm going to add a third. So one would be the group that's direct primary care, DPC. Second is traditional fee for service, and then the third I'm going to throw in here, which is concierges, and it's got some similarities, but some differences too. If you
Mhm.
were to describe that, how would you define those groups?
So fee for service is the typical insurance-based kind of practice that most people are familiar with. So you go and you pay your copay, you pay your premiums every month. So that is what we call fee for service medicine. Direct primary care, or DPC, is different in that we do not charge insurance at all. It's a monthly membership subscription. So every month, it's sort of like a gym where if you go, fantastic. If you don't go, you know you're still paying the gym, but it's
Right.
there for you. It's there for you. So,
Yes.
and that's how we are. We are there for you even if we don't see you. And so by doing it that way, we are able to have smaller patient panels, very similar to concierge medical practices. And when our patients are sick, we can see them same day or next day. We can do telehealth, portal messaging, telephone visits. It's very flexible. So that is direct primary care and then concierge, which I believe you're
I
concierge
am. Yep,
physician, right?
exactly.
So that is a little bit different, correct?
Correct. Yeah, and I shouldn't have put you on the spot for defining that. So let me I'll do this part for you if you're okay with that.
Yeah, that's
The
fine.
way I think about it and explain it to patients is you're still paying a fee and you still have a smaller panel. So that those are very similar to DPC. The difference is depending on the practice, they may or may not take insurance. And
Mhm.
so it's a hybrid in many ways. Often that you pay quarterly or annually instead of monthly. I've always envied a little bit the DPC style of, and I get the impression this varies, but some of them even keep antibiotics on hand and do some testing in the office beyond just a rapid strep or flu test. Is
Mhm.
that accurate?
Mhm. Yes,
Yeah.
yes. So
S-
we started out with dispensing medicines and yep, we do testing, we do uh, minor procedures in the office, EKGs.
mhm.
People are always shocked that we do EKGs in our office.
Yeah,
I'm like,
right. We, uh, we run into some of the same feelings. One of our nurse practitioners is a former ICU nurse, and so if someone needs IV fluids, we will often do it in our office rather than sending them out. But I probably need to talk to you offline about some of these other things because I feel like this would be a real benefit to have, and I'm getting closer and closer to just saying I can't deal with insurance and the nonsense. And
mhm,
that is what lets you do so many of the things you described: the longer visits, the personalized care, because you're not restricted by insurance anymore.
right.
Curious, do you know roughly how many patients you had when you left? I mean, I had close to 3,000, so I imagine you had a lot.
I was in a really, really unique practice. I was part time. I have 3 children, and now 2 of them are in college now, and one is in high school. But when I started at this particular practice, they were all pretty young. And the woman who started the practice was an OB-GYN, and she actually had moved away from the OB portion and was just doing GYN office and surgery, but she really had a heart for primary care. She understood that it takes time, that it's
Right?
not, you can't just rush people in and out, especially for women, because it was a
Mhm.
women-only practice. And so she had added primary care. So she was our champion. She would protect time so that we definitely had a smaller patient panel than most would have. So
Yes.
I think when I left, because I was part time, I think I had around 900 patients, which is,
Mhm. Yeah.
I mean, and the practice we left was wonderful. It's not that there was anything about the practice
Mhm.
that caused us to leave. It was
Right.
the system. Yeah.
Yes. Yeah, the system sucks. There's no
Mhm.
doubt about it.
Mhm.
And I think the older I get, maybe you've experienced this too, I've experienced the healthcare system not only as a physician, but as a patient, as a wife, as a mother, as a daughter. And if it's this difficult and frustrating for me, I cannot imagine how difficult it is
Mhm.
for people who don't have this kind of background, right?
Right.
So, all right, so this is super cool. Thank you for explaining those because I just want to make sure everyone understood the background and what you do. Let's take off the physician hat for a second. So, if I ask who is Dr. Gonzalez outside of your credentials, you mentioned you have children, but who are you? Tell us more.
Mhm. Mhm. Yeah. So, I guess I was thinking about this earlier today because I was actually listening to one of your podcasts with Dr.
Uh-huh.
Mo, and
Yes, she's
I
fantastic.
loved that. And I was thinking about taking time every day for rest and, for
Hmm.
yourself.
Hmm.
And it is true. It's easier in DPC, but like you were talking about with Dr. Mo that it's very easy to get kind of just buried in your work, and not that
Yes.
you're made to, but
Yes.
because you
Right.
enjoy it that you do.
Absolutely.
So, yeah, so once my kids were a little bit older, things that I've enjoyed doing, I am part of a choral society, and
Oh,
it
cool.
is yes, it's been wonderful. There's about 100 people,
Uh-huh.
all ages, from, like,
Neat.
college till some of them are in their 70s,
Wow.
and yes, so that's one of the things that I love, that I've been able to do.
Mhm.
Um, I'm on the board of directors now, and so every couple of months we have a concert, and so
I
it's
love it.
just something different because I've always been
Yes.
in music since
Mhm.
I was very young,
Yeah.
and yeah, so that's one thing I get to do, and then also, of course, children, I, of course, love spending time with my kids and my family, but, the other thing that I get to do is called, dragon boating. Have you ever heard of
Oh, tell
dragon
me
boating?
more. I have no idea what you're talking about. Tell me. This sounds cool.
So it is, it really is, it really is. So this is a team that was started, probably about 10 or 15 years ago, and we live
Okay.
near, Lake James, which is
Okay.
just very close. It's a beautiful lake. And so this team, it's a 20-person boat
Oh my
plus
gosh.
yeah, so it's a very long, skinny boat and 2 people
Yes.
per seat, and then
Okay.
there's someone at the front who drums during the
Oh,
race.
wow.
So, yes, and so these races are they have them all over the country.
I have to check
Um
this out. This sounds cool.
Yes, it is. It's a lot of fun, and so it's been wonderful. The team is great. Um, the women who started it were breast cancer survivors, and so
Neat.
that's why they were
Yeah.
doing paddling because of the
Okay.
motion, right?
Mhm.
So it got their arms moving to prevent the lymphedema.
Got it. What a good
So,
idea.
yes. Yeah, so a lot of the members are breast cancer survivors or other kinds of cancer survivors, or they just wanted to do something different and fun. So that's another
I love this. I have
that's
never in
another
my
fun
life heard
thing.
of this. That is
Yes.
fantastic. I will check this
Mhm.
out.
Mhm.
Maybe we'll be competing against each other someday. This actually what I'm thinking is, gosh, this sounds like a great way for my upper body strength because, as we
Yes.
go into our 40s and 50s, it's like, oh my
Mhm.
gosh, I'm so weak.
Yes. Yes.
But I love it. Oh, that is
Yeah.
very cool. Anything else that comes up that you want to share about who you are without the credentials?
Yeah, so well, this is kind of adjacent to the medicine, but the other thing that I've done in the past, well, past couple of years, I mentioned that I've been trying to mentor new DPC doctors and helping people get started with their
Mhm.
practices. But in the past 6 months, 6 to 8 months, I've really taken a deep dive into how do I help people do this. And it
Mhm.
started out with our practice. We do both direct primary care and aesthetics. And so
Okay.
aesthetics is kind of like a whole other world as far as
Yeah.
advertising and getting new patients. And so we had to learn how to advertise our practice because it's a pretty saturated market.
Yeah.
So I finally, after a couple of years of doing very poorly with ads, I finally was like, I gotta learn how to do this for real. And so I did. I took a course that was like about 6 months kind of coaching type thing.
Mhm.
And when other DPC practices talk about, or DPC doctors talk about how they're not getting patients,
Mhm.
and I hear on the Facebook groups about people struggling, I would talk to them about, well, how are you getting patients? Are you
Right.
advertising? And
Yes.
a lot of times, either they were and they weren't doing it properly, or they weren't at all,
Gotcha.
thinking that they didn't need to. But nobody knows about you, right?
Yeah.
I mean,
Yeah.
you can be in the same area for 15 years and
And
people
no
still
one
don't know
knows.
you. Yeah,
That's a good point because most of the time, especially insurance companies keep their roster, but if you're not within insurance networks, you wouldn't come up.
right. Yep.
Yeah.
Yeah, so
Interesting.
it's something that a lot of people don't understand how to do. So I thought, well, okay, let me try and help people with the ads, explaining, I started creating a course for it. But then if you have ads, but you're by yourself and you're still starting your practice, or you hadn't left fee for service
Yeah.
yet, you're trying to build your practice before you
Right.
leave so that you have some patients.
Right.
Um, if somebody calls and you're with your patients, uh, how does that help if you
Right.
have people calling, but you
Right.
have no structure? You
Yes.
have no way to answer those calls. You have no way to capture that information. And so
Mhm.
then we had started using a particular platform It's a CRM platform called High Level, and we
Okay.
started using it for our practice, and I
Uh-huh.
realized this is perfect. This is perfect for people who are, solo, micro
Mhm.
practice.
Yes.
They don't have anyone helping them. They don't have a VA, because they're just
Mhm.
starting, and of course,
A
finances
virtual
are tight.
assistant. Yeah.
Yes, yes,
Okay.
virtual assistant, right. So that's kind of my most recent passion project, is trying to help in that sense, because, people don't know about
Right.
how do you do this? If
Mhm.
you, like, for example, if you sign up for something online, like a lead magnet or something, you
Right.
want a PDF, and then you
Mhm.
start getting all these emails. Well, they're
Yes.
not doing that just
Right.
individually sending it to you.
Right.
These are automations, and that
Mhm.
saves so much time. And it, it's just one of those things that, again, you don't want to jump out of the frying pan into the fire,
Truth.
when you
Right.
leave fee for service and go into DPC. So trying to support in all kinds
Yeah.
of ways. Yeah.
You had to put on some business learning, which we don't exactly get in medical school. Um,
Mhm, mhm,
yeah, I can empathize with that. And so switching gears a little bit, I want to go back to what you're talking about. It's very uncommon, I think, that the model you described that you came from, where the GYN and the family medicine or other specialties are housed together.
mhm,
Obviously, you care about women's health, or you wouldn't have been in there. So, I think about women's health a lot. It's been in the news more and more appropriately, right? Uh, Much of what we learned in medical school was based on men's health. And I think about beliefs that we have and hold about women's health as
mhm.
physicians, as women, as mothers, as patients, all of these. I'm curious, is there a belief that you have that you just hands down refuse to compromise on when it comes to women's health?
Oh, yeah. So we have started, actually, in our practice, we have started doing some menopause, perimenopause consults.
Mhm.
And the biggest thing that, we flat out do not do is we do not gaslight women.
Love
We
it.
will listen, you know,
Yes.
and that's what
Yes.
people need. That's what people want.
100%.
They've been told or blown off, brushed off,
Mhm.
this is all in your
Yes.
head. Here's an antidepressant,
Mhm.
and that is not what we need. We need someone to
Yeah.
listen and
Right.
hear us. Yeah.
Yes, and potentially order tests that someone else
Mhm.
hasn't or wouldn't. Absolutely.
Mhm.
I agree with you. I became a certified menopause practitioner right out of residency. I realized that in my internal medicine residency training, they hadn't given us that, and I wanted it. So I've been certified in menopausal medicine since 2014, and for almost 10 years was one of two people in St. Louis, which is a decent sized city, right? Who were certified menopause practitioners. Now, thankfully, there's been more discussion about it. The media has picked this up, and more people are aware. So it's wonderful to see that growth.
Mhm.
But it was shocking to me how few people in the OBGYN world or the internal medicine world were taught about caring for midlife women.
Mhm.
And I think what was equally shocking was the idea that women aren't told this is a reverse adolescence, right? We get all the same, the mood swings, the periods, all the sleep deprivation changes. Like it's
Mhm.
literally being a
Right.
teenager in reverse. And
Mhm.
I found it very frustrating as an internal medicine physician to watch these women be gaslit and to suffer and to be told hormones are poison and maybe they aren't right, but let's at least give people their options, right? And so over the last decade, having more and more discussions in that manner, where I'm going with this is I'm curious in your perspective, what you've seen. I get the sense that women really misunderstand their bodies and they don't realize, for example, it's 10 to 15 years before they'll go through the change. So their symptoms may show up in their late 30s, for example. Do you run into certain things that women just misunderstand about their bodies in the season, 30s, 40s, even 50s? In your work, tell us more about that.
I think that it's, not that they misunderstand about their bodies, but and it's no one's fault. It's just that they're not educated about what is the biggest killer of women, right? What's the cause of
Yes.
the number one cause of death for women, which is not breast cancer,
No, not at
right?
all.
It's heart disease.
Yes.
And people don't know that. They
Correct.
come in and they are so scared of breast cancer with the hormones and,
Yes.
"Oh, my grandmother on blah, blah," "My great-great-grandma
Mhm.
had breast cancer. I can't," and
Yeah.
it's not like that. We know that that's not true and that hormones are preventive. They
Yes.
help with preventing cardiovascular disease, insulin resistance, so all of these things that and it's true. It is getting a lot more attention now. Um, Still not enough,
Right.
but it's going in the right direction.
Finally. Yes.
Mhm.
Finally. I love that you bring that up. Early on in my career, I don't remember who interviewed me, but somebody did. And they just didn't believe me when I told them that, there are more women who die both in the United States and globally every year than all cancers combined. And that was just like shocking to them. And so then I had to break it down in numbers and be like, no, 1 in 8 women or whatever the numbers are now for breast cancer, but 1 in 2 women for heart disease. And, explaining how heart disease includes heart attacks, heart failure, stroke, peripheral vascular disease, all the things. And that was just so much of a shock to this reporter that I realized I started just kind of casually discussing it with my patients. And I realized, oh no, this is like how everyone thinks about this, just like you
Mhm.
said.
Mhm.
I'm glad you bring that up. It's part of the reason I focus more on, postpartum metabolic health. So if they had gestational diabetes, helping them prevent type 2 diabetes and perimenopause. One of the things I'm going to put on my rebel hat here for a second. One of the things that I really detest about our healthcare system, as good as it is we don't take the subtle signs that women uniquely have, whether it's postpartum or pregnancy or perimenopause, and do anything with it. And yet we know that those women are so much higher risk for all these metabolic and cardiovascular events, and we can change them. It's not like we don't know.
Mhm.
And it just really gets me going. So that's my soapbox. I'll stop now. But on that similar theme or vein, being a rebel, you a little bit are because you left the system, right? So welcome to the Rebel Club. But do you think that there is advice that the current system, the traditional evidence-based system, right, is giving women across the lifespan that's harmful?
Advice, I guess really, advice that's harmful, um, not from the system, but mainly from, just the social media,
Yeah.
and that really it really can affect people even if you know and you like I'm a physician, right? And I'll hear
Right.
things and then it makes me
Yes.
second guess like, "Am I right or wrong? Am
Right.
I hearing this
Yes.
correctly?"
Correct. And of course, any conversation you have, your phone like repeats to you, and like, oh my gosh, stop listening to the conversation.
Yes. Right, but then yes, so a lot of people right now, they get their information from TikTok or from
Yes.
Instagram, and
Yes.
so, yeah, I guess it's not really coming from within the system, but,
Mhm.
certainly
Still
people are
harmful.
hearing
Mhm.
a lot of misinformation,
Mhm.
and of course, you know, I won't say anything else,
That's okay. That's okay. I think I'm reading the brainwaves you're sending here. We'll be careful. What I will say is it's tough when you have institutions that aren't respected and you have people in power that don't look at the same data the same way we do, right? We
Mhm,
literally spent a decade or more training for this. But that actually leads up to a different point that goes parallel with this. So my nurse practitioners love to harass me about this. Every time the scores come out, whatever survey it is, the nurses are the most trusted profession and doctors are lower in trust than nurses. And that was part of the reason I started the podcast. It was like trust is really a big deal when things are on the line, right? And
mhm,
the last time you want to try to create trust is in a crisis situation. And so the idea being that if we start to have conversations about who we are and what we do and why we do it, people start to understand that it's going to only make things better for everyone. But I hear often that the reason people don't trust experts or they don't trust physicians has to do with cover ups and bad science. And, certainly within our professional circles, I imagine you've seen too, where people are trying to rectify this, right? We're trying to have the conversations and say, we got it wrong. There's
mhm.
a lot of that, for example, with the New England Journal of Medicine and racism over the country and how doctors perpetuated really wrong things over the decades. So I applaud that they're doing that, but I'm curious your thoughts. You mentioned you left with around COVID finishing, right? You left your current practice. And so
Mhm.
for me, I didn't see COVID cause distrust alone. I think the distrust was there and COVID amplified it. But I'm curious your thoughts on that. What did you see in your part of the country? Just on this whole trust issue and experts, anywhere you want to go with that.
Yeah, definitely, uh, well, I think definitely now, I hear this a lot, there's a trust recession, um,
Interesting term.
and it's true, that's one of the things when you have a new patient, especially in direct primary care or, in a non-traditional type of practice because people don't have to come to you, right?
Correct. Right.
Because you're not covered under their insurance. And so
Right.
this is completely, this is more of a want versus a need.
Yes.
And so, um, they have to trust you, right? And so right now that and I think that's one of the things that I really had to learn. I mean, you learn as a physician anyway, but being independent is trying to convey that to people because they will not come to you unless they
Yeah.
trust you.
Right.
So it is, and it is harder now. I mean, for sure.
Yeah. I so here in St. Louis, one of the things that we've seen really blossom is the idea of functional medicine, um, many times chiropractic or naturopathic avenues, and people almost hesitate to bring it up to me like I'm going to yell at them or something, right? Like I'd rather you tell me what you're doing so we're all on the same team. But that is not necessarily what I saw mentored to me in medical school, in my residencies, in my early academic career, right? That was not the standard. And so I'm curious your thoughts on this. And just so our listeners understand, if you didn't grow up in healthcare, if you will, what happens through medical school and residency is very hierarchical, and you're stripped of any power, and you have to meet all the demands as you go up in order to progress. Which, after you've obtained, usually have obtained thousands, hundreds of thousands of dollars in debt, and you've spent a decade of your life, you're not really wanting to do anything except toe the line and make your superiors happy, so you can get out and graduate, go get a job. And what I'm curious about is around the topic of what we call internally evidence-based medicine. When I was in medical school, I remember being interviewed on this idea of should we practice medicine without evidence, and it seemed intuitive. Of course, we should have evidence, right? And it has been revealed over the last 15 years that we don't have great evidence for women. But that doesn't mean we have no evidence. It also doesn't mean the evidence we have is proof of harm. And so, where I'm going with this and the idea of these alternative mechanisms of medical care, where do you think the right balance is? What role do you think a allopathic or osteopathic physician, a medical doctor, has on a team that's a bit untraditional, right? And communication, and how does that fit into your practice? Anything you want to share on that?
So I think what we have learned is, mine's going like different directions here,
I know I gave you
but
a lot of places there. Sorry.
oh no, it's fine, it's fine. Yeah, one thing about direct primary care, and it comes back to having smaller patient panels, is that you can, sit with that patient, have that relationship, have the trust, and hear not only what they're trying to tell you, but then also dive deeper. Kind of
Yep.
the background, the backstory, and so a lot of times, you don't have time during a regular visit in a fee for service kind of
Right.
system practice
Right.
because your visits, if you're lucky, are 15 minutes.
If you're lucky, that's
If
right.
you're lucky, and that is very rare. So I think when you started talking about, functional medicine, integrative
Mhm.
medicine, those kinds of things, when you are
Yes.
in the system,
Mhm.
it is a knee jerk reaction to say, nope,
Yep.
don't talk to me about that
Uh huh.
because you don't have time to hear it.
And we might have been trained, at least I was, that
And
they were
you,
a little
yeah,
bit quacky, right? Like they were
hmm
weird.
yeah, yeah. And as I get older, I
Mhm.
find myself being more and more open minded. However,
Yes.
coming out of regular fee for service practice and becoming independent practice, um, having the time is nice, but also
Yes.
just why, if people don't trust the system, why are they going to a functional medicine doctor? What
Right.
is driving them there? And,
Mhm.
maybe they don't necessarily think, oh, there's something wrong with regular medicine, but they're
Right.
not getting their needs met
Right.
in the regular system. So,
Yes.
do they 100% believe whatever a functional medicine doctor is telling them? Maybe or maybe not. But you know what? They are listening to them and giving them time.
Right. Yes. Yes. And validating what they're feeling.
Mhm. Mhm.
Um, I can't tell you how many times I cringe on my former self right out of residency in an academic program. And the things that we were taught in residency to say or to react, you don't even realize it's implicit. Many times it's just what you observed. And now I find myself ordering some of those same tests, and I'm like, "Oh my goodness, my younger self would be so ashamed of me," right? But, what I love about medicine is our job is to go with where the evidence is, not with
Mhm.
where a policy or a government or an organization stands, and it's
Mhm.
okay to disagree. That's what makes
Mhm.
it brilliant for people getting personalized care. But it's uncomfortable sometimes. It is, when you
Mhm.
realize you're the, outside physician, right? And
Yeah. Yep.
for our non-medical people, that was always the term that we used internally in the system to almost capture the idea that this person was a little bit off their rocker. And now I am that person. Okay, how does this shake up with my identity and the care I want to provide and
Mhm.
who I am? So, before I get on another rabbit hole, let me come back to DPC just for a second because I suspect there could be people in your neighborhood who hear this and um, maybe they're not in your neighborhood, but they just want to know, well, how do I find a DPC doctor? Like, because to
Mhm.
your point, like, unless they're advertising, what would you recommend to someone who says, I want to check out this model?
Right. There are several DPC mappers. Probably one of the biggest ones is called I think if you just put in DPC mapper into Google,
Okay.
it'll bring it up. The website is called DPC Frontier, and so that
Okay.
has a probably majority of all the DPC practices that are out there. There's
Hmm.
not many. There's about 3,000 probably across the country, but most places have at least one.
Okay.
At least major cities will have
Yeah.
multiples, but
Yeah. I
yeah.
think we have two or three that come to the top of mind. I think you're right. I recently was looking at kind of what kind of conferences and education do I want to get right in the next year and planning that out. And I didn't see a lot. So maybe you can direct me for learning more how to provide care and the business model of DPC. Did
Mhm.
you happen to come across any of that
Mhm.
or do you know of
Yes.
resources?
Yes. So the DPC Alliance is kind of the organization, grassroots, I should say, grassroots
Mhm.
organization that represents DPC doctors. And so
Okay.
they do a wonderful job of educating uh, physicians about
Mhm.
DPC and then trying to educate the public about DPC. So they have a very large conference once a year. Last year it was in New Orleans in July, and I think it's kind of the same time again,
Okay.
also in New Orleans.
Cool.
But that is the biggest DPC conference, and that's one where they talk about, how do you do this, like
Yeah.
from the ground up, and
Very cool.
it's a great conference. So if you get to go, I would recommend it.
I
And
love it.
then yes, and you meet a lot of people. It's kind of like meeting your people, right?
Mhm. Coming home.
And yes, and people say it's the happiest physician conference they've ever been to.
I love it.
Yeah,
I love
so
it.
that's one way to learn how to DPC, and then the Alliance also does masterminds throughout
Yeah.
the year. And so
Okay.
I went to one before we opened, and that was
Uh-huh.
great
Okay.
because you get to meet people who are kind of in the same stage as
Mhm.
you, and it's kind of like it's a bonding experience, and so these become
Yes.
your people, your supporters, and so they're the ones you can go to when you have questions or things are just not going right.
Right. Which that
Yeah.
will happen.
Mhm.
Guaranteed
Mhm.
in business. The reason I ask, of course, selfishly is for myself, but also for our listeners who are clinically trained and are thinking about making the move, that's where they should go. For our listeners who aren't clinically changed, but you know that doctor that would really be a great DPC doctor, give them a nudge, tell them about this
Mhm.
and spread that because I firmly believe we will not see effective change within clinical medicine and healthcare as we know it in the United States without our patients being involved. I don't think this is something we can only get with medical professionals taking
Mhm.
stance. Uh, My opinion only, but I think we need our patients
Yes.
to help
Yeah.
make this
Yeah.
change. So we'll pivot again. I've got lots of rabbit trails here. So if you get one in your brain you want to go down, you let me know. But we've talked about different things. We've talked about the business side. We've talked about what the model is, a little bit about women's health. I'm curious, what have we not talked about that's important to you that we should go down?
Oh, let's see. We've talked about a lot already.
I know sometimes it's like, what have we not talked about?
Yeah, I think that because I come from, the DPC world, um, I think it really is important to really think about, number one, if you want to do DPC, really understand what you're getting into, because I think sometimes people get into it and what they see is, okay, I get to make my own schedule. I get to do, these different things, which is,
Mhm.
yes, absolutely. You get to. You also get to take care and run a business, take care of and run a
Right.
business.
Yes.
And, when things go south, you're the person in charge.
Yes.
Yeah. And that's
Uh,
tough.
It is tough. And in your medical training, did you feel like you got any education, whether it's medical school or residency, on just the business side of medicine? And, for example, how to code with insurance or how to do prior
Hmm.
authorizations? Like, was that all taught to you? Or did you walk in residency and attending and be
Uh,
like, oh my gosh?
we got a little bit, and I think we
Okay.
probably got more than most, especially
I don't
about
remember
coding.
any. Okay.
Yeah,
Yeah.
coding. But then at that point, because like people were not opening up an independent practice. I mean, if
Yes.
you told me when I got out of residency that
Right.
20 something years later you'd open your own practice, I'd say you are crazy.
Yeah, I would have
No
laughed at
way.
them. I
Yeah,
thought I'd be in academics all my life.
yeah, yeah. So
But that was the only world I
we got
knew.
a little bit. Hmm.
Okay, very cool.
Yeah.
The I think the thing that was most shocking to me when it came to billing and coding and the business side is people would come in for their annual wellness visit, and they would literally have a laundry list. Now, what's interesting time-wise, I finished residency in 2013. Obamacare kicked in my senior year of medical school, so 2010. So by the time I became an attending, it had really started to finally be implemented and we were executing on the different things. And people who for years had brought in their list for their annual appointment were suddenly being told, oh, wait, no, you don't get to do this because there's only certain things we can cover. And it was based on what the US Preventative Service Task Force considered preventative, and it had to be at a certain level within their recommendations. And I found myself taking so much time to explain to people, listen, we can cover your list, but you're going to get a copay, or we cannot, you can come back. And it was so dissatisfying as both a physician and on the patient side. It was
Hmm.
maddening, frankly,
Hmm.
um, that it really caused me to start at an earlier point in my career, I think, to reflect on like, this was a good change. We need to do good preventative care. Our country needs us desperately, but this is the wrong way or an ineffective way to approach it. As you reflect on that time for yourself, because I think you were still within fee for service at that time,
Hmm.
I'm
Hmm.
assuming that that same thing happened within family and community medicine as it did with internal medicine, correct?
Oh, yes, yes. Hmm.
Do
Yeah.
you think that started or added to the cracks in trust? I'm going back to our trust conversation earlier
Sure.
because I'm trying to encapsulate for even for myself, like where we went wrong so that we can learn from it
Hmm.
as a profession.
I think we went wrong way before that, but
Yeah, for sure. For sure. Excluding women from studies would be a start.
but, yes, as far as yeah, there's a big disconnect because what people think of when they think, "I'm going for my physical,"
Yes.
right? They think that they're going to get their questions answered, not, "Did you, get your colonoscopy?" I mean, it's
Right.
important, not that
Yes.
it's not important, but
Right.
there is that disconnect of, "Well, what am I coming here for if I'm not
Right.
coming here to
Right.
get my questions answered?"
Correct.
And
Yes.
yes, so yeah, it's terrible, like you said, on the doctor side and on the patient, and then staff. The staff are the
Right.
ones who are telling patients,
Yes.
"You can't talk about this." Like
Right. Right. What do you mean I can't talk to my doctor?
right, and it was, there's always, good and bad of what happened, but
Mhm.
yeah, and that's why, I like DPC because we don't have to have those conversations where you can't
Correct.
talk to me
Yes.
about this, that
Yes.
it is it's very free form as far as
Mhm.
what we need to talk about. We get through the things we have to talk about, but
Right.
the co-pays, um, that's not an issue. People wait to go to see the doctor. That's one of the things that
Yeah.
they do is they wait for their annual visit
Right.
to tell you their laundry list,
Mhm.
and they'll tell you your laundry list and then wait another year to tell you about anything else.
Correct.
And that's how people get so sick, right?
Correct. Yes.
And that's why we love DPC. We love that kind of model because the money is not going to be holding you back. That
Right.
you're not worried about paying your $25 or $50 copay because you don't have it, but then you
Mhm.
have terrible diabetes and
Right. Yes.
your foot is infected.
Uh-huh.
And then
Exactly.
you're in the ER and going
Yes.
to stay for IV antibiotics.
Well, and to add, right, so our non-clinical listeners may not understand this. So when you're wearing your physician hat in that encounter, you're also being judged by how many check boxes of preventative things did you do, both by the insurance company and your employer. And so
Mhm.
there's real competing interests there. And
Mhm.
they're supposed to be patient centered or patient centric, but it certainly is not experienced that way by the patient. Uh, and I can totally agree how many times, and it tended to be patients in their 50s, 60s, 70s, because that's how they were trained, right? Is to come in once a year and give you your laundry list. But that just wasn't the system in their 20s and 30s and so forth that our
Mhm.
current 20 and 30-year-olds deal with. And so as we close and I'm thinking about preventative medicine, and I just love what the work you're doing and how you're brave enough to try to do something different, right? Like that is huge in itself. If you have a message to give in terms of preventative health for our listeners, for the women out there, what would that be?
I would say, listen to your bodies,
Mm.
right?
Yes.
Listen to your bodies, pay attention to your symptoms because that's one of the things, for example, heart disease, women do not present the same way as men do. It's not like,
Right.
oh, it's the big one.
Yes.
It's like,
Yes.
oh, I have a little indigestion when I walk up that hill. Like
Mhm.
that's not what that
Right.
is. So
Right.
pay attention. And yes, I know we talk about, not having time, but, make the time with your physician.
Yes.
Tell them about your
Yeah.
symptoms.
Yeah.
Mhm.
This is so true for me, as I reflect. One of the ladies in my church group recently dropped dead from a massive heart attack in her 40s.
Mm. Oh,
And
gosh.
you think about that, and you think we always think we have more time than we may have. And so I think your warning is well said that number one killer of women is heart disease. And if you have symptoms, you're not making them up. Your body's talking to you. Take it seriously. And what's the worst case scenario? You took an hour off of work and got checked out and know it's not your heart, right? That is much better worst case than a sudden death, which is the number one sign of heart attacks is sudden death.
Right.
So to our listeners, please don't think that you will necessarily have the time that maybe you would assume you do. Listen to your body. I love that. And I'll build just a little further on it that if you had preeclampsia in your pregnancy, if you have symptomatic hot flashes as you go through the change of perimenopause and menopause, those are warning signs of cardiovascular disease. So find someone. You can go to the Menopause Society and find a certified provider or someone who's at least interested in that. You can talk to your friendly DPC expert in your town, and they'll have the time to research it, go further. But find somebody because there are people who can help you. So, thank you, Dr. Gonzalez. Thank you so
Of
much for
course.
being
Thank
here.
you.
I've loved learning about what you're doing and what I just think there's so much potential in your future. I'm so excited to
Yeah.
follow
Thank
you
you.
and learn more.
Yes. Well, thank you for
For
what you're doing.
absolutely, this is, I think the happiest time in medicine for me is because to what you said earlier, we can finally listen to our patients and can show up and be the healers that we're called to be, that we
Mhm.
weren't before. So, for our listeners, if something in today's conversation resonated, it's because you're not alone and you're not imagining it. You can find more support and resources, next steps in the show notes. We'll put a way for you to connect with Dr. Gonzalez on her social channels and follow her as well. If this episode helped you feel seen, if you are validated, share it with a woman who also needs to hear it. And next time, we'll talk about more with our next guest on the Authentic Physician Show.